A 60-year-old man is hospitalized for a urinary tract infection. The patient is given antibiotic therapy and blood cultures grow Escherichia coli. 2 days after admission, the patient develops chills, shortness of breath, and a non-productive cough. His temperature is 101 degrees Fahrenheit, 38.3 degrees Celsius. Blood pressure is 95/62 millimeters mercury. Pulse is 115 per minute, and respirations are 25 per minute. Chest X-ray reveals bilateral infiltrates with no evidence of cardiomegaly. Which of the following is the most likely cause of this patient's respiratory symptoms? Choice A, capillary endothelial cell damage. Choice B, toxin causing increase in intracellular CAMP. Choice C, alveolar wall thickening. Choice D, inflammation and exudate formation. Or choice E, trauma. I'll wait 5 seconds and answer the question. So this patient obviously has sepsis, right? You have the fever, tachycardia, tachypnea, and you have an obvious source of infection from the UTI and the E. coli bacteremia. And sepsis is, of course, one of the most well-known causes of ARDS, acute respiratory distress syndrome, which is a diagnosis of exclusion, but it's caused by an inflammatory process which damages your pneumocytes. It can be both your type 1 or your type 2 pneumocytes. And it would cause a respiratory failure, which, like I said, is a diagnosis of exclusion. You need to rule out the possibility of other causes, such as volume overload or heart failure, and it will usually result in bilateral infiltrates. So like I said, this is caused by an inflammatory lung injury, which damages the pneumocytes, and this ultimately results in the release of various cytokines, which will damage endothelial cells. So choice A, capillary endothelial cell damage, is the correct answer. And of course, once you have endothelial cell damage like this, you can cause leakage of fluid into the alveoli, which is what causes the bilateral infiltrates in this case. And of course, ARDS being a diagnosis of exclusion, it can be difficult to tell when it's ARDS and not just an infection. And in fact, there's actually a lot of overlap there as well. So let's just move on to the incorrect answer choices here, and I'll expand on that idea. So first, choice B, toxin increasing intracellular CAMP. This is a throwaway answer meant to trick some of you that studied your microbiology really hard and you know that E. coli can cause intracellular CAMP increase through the ETEC toxin. But this is an enterotoxin that leads to watery diarrhea, so it's actually totally unrelated here. And of course, I would be remiss not to mention the Shiga-like toxin, which is also associated with E. coli, EHEC 0157H7, which of course would cause hemolytic uremic syndrome. We will have schistocytes on blood smear. The Shiga-like toxin attacks the 60S ribosomal subunit, causes endothelial damage. You'll have platelet plugs. Red blood cells try to travel through platelet plugs, they get sheared and then turn into schistocytes on blood smear, and it usually has bloody diarrhea associated, which is why it's considered one of the MAHAs, the microangiopathic hemolytic anemias. It's just one of those things that's pretty high yield about E. coli you need to know. Choice C, alveolar wall thickening. This is referring to the interstitial lung disease. I mean, just logically, you can think of alveolar wall thickening as a more chronic thing that would occur over time. So it's more likely this would result from chronic conditions such as environmental exposure, such as pneumoconioses, granulomatous diseases such as sarcoidosis, hypersensitivity syndromes, and autoimmune disease. So stuff like rheumatoid arthritis can actually lead to rheumatoid lung, which is an interstitial lung disease. And of course, you have some drugs like bleomycin, where they occasionally test on them causing interstitial lung disease. This patient doesn't have any things that would indicate that he might have interstitial lung disease, and obviously has the elephant in the room, which is his sepsis. Choice D, inflammation and exudate formation. This is just referring to pneumonia. And as I already mentioned, pneumonia and infections in general can also cause ARDS. Now, I think it's doubtful that USMLE will ever ask you a pneumonia question and ask you to be able to differentiate between pneumonia and ARDS in terms of what damage it's actually causing to the lungs. Because when pneumonia causes ARDS, it's kind of both happening at the same time, right? You both have the bacteria in there causing whatever direct damage it has to the lungs, and that will further lead to inflammation, which can cause ARDS, which makes it even worse. So if you get a question about pneumonia and for some reason they ask you about ARDS, I think it's very unlikely they're going to give you two different answer choices where it's like one is infection or pneumonia and the other one is ARDS. It's more likely to be a case like this where I give it to you. It's clearly a response to a bacterial infection that causes ARDS. And I give you multiple hints in this question, right? Because I tell you he has a non-productive cough. And I tell you bilateral infiltrates, which is not really what you typically see with a bacterial pneumonia, which is usually a lobar pneumonia. So the point here is that you need to take the various information that they give you in the question if they really wanted you to differentiate between pneumonia and ARDS. But of course, what I'm also telling you is that if you have pneumonia, ARDS kind of results as well, and it will be difficult to draw the line between which one is happening in terms of the actual pathology. Choice E, trauma. I mean, this is kind of a distractor. Trauma can also cause ARDS, and this patient has no history suggesting trauma. And even if it was trauma, it's more likely I would give you an answer choice like A, where it's capillary endothelial cell damage, because that's the actual specific cause of ARDS and not necessarily the trauma itself. So bring it back, you just need to understand ARDS as a diagnosis of exclusion. You just need to know that inflammation can cause cytokines and it damages pneumocytes and increased permeability in endothelial cells, which might also be damaged. Damages the ability for gas exchange in the alveoli, and it also causes fluid to start seeping into the alveoli, essentially. Hope you found this video helpful. I'll see you in the next one.